So let me begin this session, and I'll be talking on a project. These are all USAID based projects, and this particular project was carried out in the year 2014 to 16, which is on the screening, treatment and rehabilitation of children with low vision. Slides? I can see it here. The slide is not moving from this. Yeah. So, talking about the magnitude of low vision, so the magnitude is quite big, with around 285 million vision impaired and 39 million blind people, and most of these blind and visually impaired live in the developing countries. So, as we can see from this graph here, most of the developing countries, including India and China, have the maximum number of people with vision impairment, and this statistics is from the global impairment by WHO. And also, when we see the causes for blindness as a percentage of the global blindness, the cataract is the maximum, both in total blind and vision impairment, followed by refractive errors and many other causes, including corneal, ROP, and retinal, including age-related macular degenerations. So, coming to the present scenario in India, the prevalence of the functional low vision is about 2.5 per thousand population. But the problems are lack of awareness and professional assessment, lack of early intervention, and we do not have comprehensive low vision care in many places. Access is poor and stigma to use devices. So the barriers to low vision care in India being it has always remained a low priority. There are very few centers specializing in low vision care, with poor access to services, poverty, illiteracy, and social stigma. Many people do not like to use these devices in public. Lack of awareness and lack of affordability, and also children with low vision are studying in blind school. Aging and increased longevity is also will increase the population of people with low vision. So we need to have the scope of services at the primary level. We need a lot of around 2000 centers for the current prevalence, and secondary around 400, and tertiary at least 100. And the primary level being mainly manned with the primary health workers, community health based rehab workers, and teachers. So at the primary level, they can liaise with the MLOPs, where they can do a basic refraction and low vision assessment, and they can dispense simple devices. And we need to work at the grassroots level with the school teachers, special educators, social workers, and volunteers. And at the secondary level, we have community centers and regional hospitals, where you can man it with ophthalmologist and optometrist and rehab health workers and volunteers. And there again, you can have some degree of linkage with the educational outreach services also. And here at secondary level, again, we can do refraction, prescription of devices, diagnosis, assessment, and vision training. And a few complex cases can be referred to the tertiary care centers. So at the tertiary level, again, we have the ophthalmologist with optometrist and rehabilitationist, because rehabilitationist is very important at the tertiary level, so that they can do a proper functional vision assessment, train to use the low vision devices, orientation, mobility guidance, and educational vocational guidance, and rehab counseling. So with these in mind, because we were not targeting the grassroots level, most of our treatment was only for patients who are reaching the base hospital. So we plan to do a community based service for children with low vision in the area of Coimbatore. And the objective is to enable early identification of children with low vision in community and refer to base hospital, subsidizing the cost of low vision devices for people who cannot afford to buy them, upgrade the existing low vision clinics, and increase the capacity to provide better services, and expand coverage in the surrounding districts. And so we had included the vision technicians at our vision centers, field workers, key informant strategy, SSA teachers, who formed a major bulk of our project by identifying these children, school teachers, Anganwadi workers, primary healthcare staff, and blind school surveys. So these are the pamphlets we had made, and we had given a training to the field workers and the vision center technicians. Key informant interview from a variety of people, including like Panchayat presidents, Anganwadi workers, PHC staff, village health nurses, PHC, refractionist and community residents. And the teachers training program was done with the help of SSA teachers. So the number of teachers who participated from the districts was quite promising. In Coimbatore we had around 98, Tripur around 22, Erode 70, and Salem was around 89. And these were the details of the camps that we conducted, and we could identify a lot of children in this way. So these are the photos taken by the school teachers who had shared with us during the time of the project, where it is seen that the children did not have much stigma to use the devices in their classrooms. So this is the Anganwadi screening by the field workers, and we had done camps in even far-flung areas as a part of this project, including camps for the tribal population in remote areas, and special schools and non-governmental organizations also were screened, where we found a lot of children with multiple disabilities also having low vision, like children with autism and cerebral palsy, who are being identified and given appropriate services. And this was the camps in the special school for the blind, where we could identify few children and also few children who are having cataract who are operated as part of the project. So this is the screening details. In the end, we can see that the field workers and SSA teachers had contributed to the maximum number of children screened and identified, and out of which the refractive error, whoever needed glasses were corrected. Surgeries were also done as part of this project free of cost. So we and identified around 1600 kids with low vision, and we had given the respective interventions, including glasses, devices, and surgeries were also done, and a few of them for early intervention training. So the expected outcome was to enhance the system and processes for identification of low vision cases. So even after the project ended, we still have touch with all these people who even now refer cases to us, and capacity building of organization to provide a comprehensive low vision service and rehabilitation services. Thank you very much.